Hi, I'm Lindsay, and tonight I'm going to talk to you about distributive shock. What is distributive shock? Excessive vasodilation and the impaired distribution of blood flow. The most common type of distributive shock is the septic shock. This is the leading cause of death in the ICUs right after cardiogenic shock. During distributive shock, patients are at risk for diverse organ system dysfunctions that may progress into multiple organ failure. A few other causes of distributive shock are systemic inflammatory response syndrome from burns or pancreatitis, toxic shock syndrome, anaphylaxis shock, neurogenic shock, and heavy metal poisoning. Patient assessment. Symptoms: change in mental status, heart rate greater than 90 beats per minute, hypotension with systolic blood pressure less than 90 millimeters of mercury, respiratory rate greater than 20 breaths per minute, warm extremities with bounding pulse, hypothermia, core body temperature greater than 38.3 degrees Celsius or 101.1 degrees Fahrenheit, hypothermia, body temperature less than 36 degrees Celsius or less than 96.8 degrees Fahrenheit. Hypoxia, decreased urinary output. Underlying causes: bacterial infection such as pneumonia, urinary tract infection, and gangrene. Anaphylaxis causes respiratory distress, rashes, angioedema. Toxic shock syndrome causes rash, high fever, hypotension. Adrenal insufficiency causes hyperpigmentation of the skin. Oral and vagina and anal mucosal membrane may be present in chronic adrenal insufficiency. Test to determine distributive shock: CBC, urinalysis, electrolytes, blood, urine, nitrogen, also known as your BUN, creatine, glucose, urine cultures, blood cultures, ABGs, serum lactate, especially with metabolic acidosis if elevated iron gap is present, sputum sample, gram stain, culture, and electrocardiograph should be performed to examine the patient for evidence of underlying pathological cardiac conditions or acute changes in ischemia or pericarditis. Hemodynamic monitoring and findings. Distributive shock: pulmonary capillary wedge pressure is normal or decreased, and cardiac output is increased or normal. Arterial catheter placement should only be considered in hemodynamically unstable patients who are receiving continuous infusions of vasoactive drugs or in patients requiring frequent arterial blood gases. Pharmacological treatment for distributive shock: fluid resuscitation, antimicrobial regimen to kill pathogens causing shock. Systemic vasopressors is indicated in patients with hypotension due to sustained septic shock in whom fluid resuscitation does not revive hypotension. Antibiotics to fight bacterial infections. Corticosteroids are used for their anti-inflammatory properties. And vasopressors, these agents augment coronary and cerebral blood flow present during the state of low blood flow. arterial blood gas, and mechanical ventilations. ABG should be performed to monitor the patients on the ventilator. Mechanical ventilation should be done electively if possible to prevent respiratory arrest. Mechanical ventilation can also aid in the hemodynamic stabilization by decreasing the demands posed by the respiratory muscles on the circulatory system.